So let's move to another topic, that is the facial restoration. Of course, you can use the same treatment protocols also for surgical aspect. That means that you can use fat for doing the same things. But of course, we want to start with non-surgical approach. So what we can do with fillers. Basically, actually, all the techniques that are proposed are mainly for deep fillings. That means that we are over the bone or in the deep fat compartments, because we believe that treating the superficial fat compartments can lead to unnatural results, especially when we inject the cheekbones. When we inject into the superficial compartments, we see the movements of the gel that is not natural. But my approach is completely different. It starts from the superficial compartments, because I want to show you a different idea. These are my disclosures. Very quick disclosure. I'm luminary and trainer for many companies, fillers companies, laser companies. I've started almost then, I think, okay, made more than 10 years, because otherwise I look like too old. Speaking for many laser companies, then I move it to injections, and then I mix it up. Treatments with lasers, fillers, and surgery. Because anyway, the combination, because we are surgeons, so it's easier for us to think about combination treatments, gives better result, especially for younger patients. When we start treating them when they are very young and they arrive at the time in which they need maybe facial lifting, but we pre-treated them, the facial lifting looks natural, exactly like the treatments. So because I'm a surgeon and also a trainer for fillers, I understood that basically that was a lack between cosmetology and surgery. There are many things that cosmetology doctor do and push too much forward closer to the surgery, and a basic lack of things that surgeon did not before the surgery to give natural results. So there was something missing in between this, because surgeon, we are too much convinced that cosmetology is something that is not really important, and cosmetology, they believe they are good, and surgeons do not understand anything, and we do not mix the two things. When we see patients that were already treated, like in that case, that was an injected patient for one of my courses. And she was not really young, not really old, around 40, but she was unhappy from the filling. Because the filling, she said, I look like filled, but not rejuvenated. And this is the point. We look patient that looks like filled, and we see them and we think that they got treatments, but they look unnatural and not really young. And I started then understanding that we needed to change something in our practice. And my point of starting point for my treatments was also coming back and watching patient with a baby eye. Because if you give a baby a picture of a patient injected, he says she's old. Anyway, so maybe they are seeing something that we miss it better than us. Because we have in our eyes, I think, the perfection of beautification and beauty in general. So I stepped a little backward and started to understand what I was doing, because I was injecting in the same classical way, but I started thinking I need to change something in my practice, because I want natural look. I want to look natural by myself. I want to look over-injected. I prefer wrinkles instead of looking like over-injected. So let's start from this patient. She's over-injected, and we completely see the difference between the frontal part that is injected in the deep compartments and the back part that is completely empty. And in many patients, we see this, because basically, as surgeon, we know that we have ligaments in face, and we can recognize in older patients, when they start aging, these compartments very well that are divided by ligaments. So basically, in older patients, we can recognize all the different areas of the face that are divided by real ligaments or pseudo ligaments, but anyway, this compartmentalization. So what I basically believe that the superficial fat that is deeply attached to this mass can act and play a role in this rejuvenation process. And basically, it acts also like, I say, a spacer between the skin and the muscle underlying underneath, so we don't see in patients that have thicker fat superficial compartments all the aging process that is going down. So maybe that means something. So I think that in the process, we lose this superficial compartment before losing the deeper one. So stepping backward, we need to restore this in a natural way. That means that we need to restore it in a very smooth and thinner layer instead of injecting a lot. And we need to work also on these ligaments, because these ligaments are also made by hyaluronic collagen and elastic fibers. So these ligaments ages like the skin in the same way. And basically, there are a lot of surgeon and publication that says ligaments become stronger and stronger during the aging process, fibrotic, and this is the reason why we see them on the skin. But there are, again, other publications, because if we read and try to understand what is happening, that says us this ligament become weaker and weaker. And this is the reason why they are not able to keep the skin in position during the aging process. So what's the truth? Because it's important to understand. Of course, I have my theory about the ligaments. And I think that both the theories are true, because they lose their ability, because when a thing is not elastic anymore, it's like a fibrotic tissue. And because we lose elastic fibers at 40, 75% of the activity of our elastic fibers in the skin. Of course, the ligament is there, looks like fibrotic, but is not able to sustain the skin on the line. So my idea is to approach the superficial fat compartments, reducing the tension of the ligaments into the superficial compartments. What does it mean? Many surgeons, they say they reduce the activity of the ligaments in the deep layers. So they say, I go through the tear trough, I destroy the ligament of the tear trough, and I restore the aspect. But when we open cadavers, we see that the ligament at the level of the bone is very strong. Is almost impossible to destroy with a smoother and soft cannula a ligament deeply attached to the bone. What we can do, we can act into the superficial, because real ligaments, they start from the bone and arrive to the skin like a tree. And I will show you the publication of Bendelson. So they are strong at the bone, but in the skin, after this mass, they are quite weaker. Other are pseudo-ligaments. They only start from the muscle to the skin, and again, we can act on that level. So we treat the fat compartment, and we treat the superficial ligaments that we call retinacular dermis. We need to work also with the neuromodulation if we want a natural look. So we restore the superficial. We don't see the muscle underlying. But because the muscle is hypertonic, hypertrophic, it will very soon restore the line. So this is why we need to make the neuromodulation. And what we know about the neuromodulation, the recent publication that we saw during the past 10 years, but we didn't completely understood, but now they demonstrated that, is that when we treat the upper third with a toxin, the brain believes that these muscles are dying and aging. Because for us as humans beings, but we anyway we are divided from primates, and we uses this muscle for communication for our brain. He believes, okay, they are dying, we need to have stronger muscle. So the brain gives more impulses, but because it's not able to act where we have the toxin, it is acting on the lower face. So you will see also my patients that are 10 years old, that means perfect in the upper, and they really look old in the lower face. I was watching that and didn't understand it. Now I know. That's why when I do toxin, I always do a full face approach, even if they don't need it. With a very small doses, that means that I never block, because if I never block, I never give impulses for death, because an hypertonic and hypotonic muscle for the brain means something pathological. If I have a good movements, it's something okay for the brain, so it acts giving us a long-lasting results, and you will see the approach. And then we move to the all areas of the face that are aging. deep fat, because now we can approach naturally, and mainly bone. Because again, also for the neck, when we see neck sagging in many pain patients, is because we also lose the support of the mandible, because we know that the bone of the mandible will shrink, especially being shorter and smaller. So if we start restoring the good shape of the mandible without giving a very sharp aspect, but just restoring, we can again treat all the aspects: skin, superficial fat, muscle, bone. So what we need to do is to approach all levels. You see, this is the publication of Mendelssohn. This is the ligament. You see very strong attachment to the periosteum. Then it becomes weaker and weaker. But it passes through this mass. So somehow we can act also on mass movement if we work on these ligaments, and we will see that is true and long-lasting. And again, the attachment to the dermis, they are very weak. So if I try to undermine under this, I can reduce this attachment and give another position in another level. So my technique that is registered and is on the publication is in this level, the number 2 of Mendelssohn, in between the skin and mass, where the superficial fat is located. You will see exactly how it works. So I divide the face, first of all, in circles, because I don't believe that we have to watch at faces dividing upper, medial, and lower faces, because in this way we lose the homogeneity of rejuvenation. So we only think I wrinkle hair here, but I don't see all the sagging underlying. Dividing in circles, we pass through these ligaments in reality. So one circle is at the external canthus, the other one at the level of the eyebrow, and we have located underneath specific ligaments for that, so we know exactly where to go when we inject. And this is exactly the anatomy of all the ligaments. We have many in the face. This is a description. Any surgeon calls the ligaments in a different way, so we have a description of different names, but basically the ligaments are always the same. This is the publication. And why I do these circles, because then I can identify the area where I want to inject, an area in which I don't want to inject. I don't know, it's not, is this located? This yellows goes inside this triangle. Because there, where the yellow is where is located what we call like the, is a kind of bag, that is a zygomatic bag, that is located into the superficial fat. So if I inject hyaluronic acid there, just because I didn't know, this bag will increase. And we stay there forever, because we have two ligaments, orbital retaining and zygomatic retaining ligaments, in between of them. So you will have a defect that will last at least for 1 year, sometimes 2 years. So the only way is to use hyaluronidase. So we never inject into the superficial plane in that level. We can work everywhere, all around the face, but not and never into this. And with this technique, with the circles, you can identify very easily what to do. So what I do, I identify my entry point that is in the center of the cheek, as you see here. And I start with my cannula undermining under all pseudo and real ligaments into the superficial plane. That is quite easy, especially where I have attachments. So my cannula moves also where I have retaining ligaments, orbital and zygomatic, but I do not inject. If I want to inject, I go deep, only in that area. Otherwise, I inject everywhere, giving this smoothness. What I have to use a gel that must be elastic, because I need a kind of lifting effect, and must be small. Otherwise, I give like a puffy face to my patient, because I don't want to give this. Or if I want to give a little bit of volume, I can use a little bit middle particle gel, but must be elastic. What happens to my retinacular dermis? In my imagination, because of course, is a theory, is not the truth. Every time we tell a story and about what we think is just what we believe that happens, is this. I rejuvenate these attachments, making them more elastic. Because what I have in my patient is that if I then try to have this test that is called the shrinking test, because I can test the elasticity of my skin. If my skin is very well attached, that means that my ligaments are very elastic. You see, how is your skin? Try it. Okay, try my skin. How old are you? 26? I'm 45. But treated, of course. Yeah, because this is very important to give the tension of the skin. And because she's young, she's not doing the test. But after 40, what we do always is the mirror test as a female, because we take the picture like that when we age. You can take the picture like that. I cannot. Okay, I need to take the picture like that, otherwise my skin sag. But my skin is not sagging because I'm treating my skin to give elasticity, but not giving volume. Otherwise, I look like injected. And I don't want to look like, I prefer to age a little bit instead of looking like aged. So my theory is to work in all this area. And if you start when you are young, this is even better because you keep the elasticity. Because at 25, we lose 50% of elastic, hyaluronic, and collagen. At 40, we lose 75%. At 50, we lose 93%. So when I have a patient that is 50 and comes for my clinic for a facelift, I need to deal with a skin that have no elastic fiber, no collagen, and pretend to have a good result only from the lifting. And maybe she stayed at the sun for the last 10 years, destroying completely the elastic fibers. So I never do a lifting in this patient. I start with a rejuvenation process and then maybe move to a lifting, because then the result of the lifting will be stable. So mixing surgical and non-surgical will give us more results. So this is the technique, but it's important to see. You can completely understand. But I want you to understand that when, this is one of my patients, you see during the activity, again, we spoke about dynamic breast, we speak about dynamic face. Because a face after treatment and injection can be fantastic, but when they move, we see the gel. Oh, why she's doing this and why she's moving that? Because we can really see the gel during the action of the face. So the first thing for me, they need to be natural, statically and dynamically. It's always the same point. Natural things must be natural always. So I asked my patient to make movements, and then I see that the movements in the upper face, where I did toxin for 10 years, were still quite good. But look at the lower face, it's a disaster. So we can see everything, and the muscle, the mentalis is so strong that you can see that she's 40, only from the lower face. So I need to work a little bit on this. Why? During this mixing of the superficial approach together with the toxin, so we reduce, she still moves, so even if I do my toxin, I can move, so you see me making faces and acting, but I don't see mandibular border laxity, because when we have the sagging in this area, we are more than 40. Simple. It's so easy for me to give the age to my patient because I see just few things. If the ligament is there, where is, and how sagging I have. Then I can say if she's 30, 35, 40, 45, 50, or whatever. In my patient, I need to remove this. You see them, but you don't really understand exactly. She can be 40, what you thought when I came here. She can be 35, she can be 40, but you need to guess. This is okay for me. I love guessing, but then you had my age at the beginning, so it doesn't work. This is another patient. You see from the lower face, again, the same thing. Quite good in the upper, terrible in the lower face. When I restore them, they look natural. So you don't see that they are injected. This is so important for me because I want to give natural result. So not necessarily big cheeks, big lips, but just rejuvenation, because we are speaking about the rejuvenation, then we will speak about beautification. That is a different thing. And we really need to understand the difference between beautification and rejuvenation, because many injectors, they do the same techniques for rejuvenation that they do for beautification. But if I try to inject the cheekbone to lift the skin, but I've lost already 75% of my elastic fibers. I will keep my filling after 1 month, and the skin will be again down. So the patient come again, okay, I need to inject again, and you do another vial. So the skin will be, again, distressed, but in 1 month, the skin will be down, and you have 2 vials of filler into the cheekbones, and they look like all like, a puffy and a balloon face. So I always treat all the muscle of the face, very low doses. You see 5 units, 2.5 units for each muscle. So you still move everything, but basically you are treating all the muscle to reduce hyperactivity. You can do more, you can do less depending on the patient, but I do suggest to treat all the face always. This is another patient. You see again, good skin quality. I do a lot of laser in my patient. They do a protocol also with laser. But look at the lower face. They can immediately understand she's 40. After, even if she's very strongly contracting, and you can see from here, you don't see the action, and you see still a good border of the mandible. So my goal is to have this that is very similar to a lifting. Sometimes I make a guess with my colleagues that are only surgeons, they only make lifting, and I show them that I have long-lasting results that are very similar to lifting sometimes, just using non-surgical techniques. Because if I have in my hand only the scalpel, I have to use, and I'm forced to use only the scalpel. But if I have 5 options to my patient, I can be more flexible. And this is good to be, very well experienced and quite a bit younger, because I can mix things. So again, we need to correct the bone, because if I correct the skin quality, I correct the muscle, but I don't work again the aging process of the bone, I still look injected. So before injecting the deep fat compartment, that's very important for me to give this message to you. First, let us restore the structure, because sometimes we inject the deep compartments and we think that is good, but this needs to be the latest thing we do. We first restore everything, and then we inject the deep compartments. And we see the bones that is aging. We have the eyes that become larger. So even when you treat the tear trough, if I try to inject the tear trough before restoring the orbit borders, what I see is like a bubble in the middle here. And again, this is not a correction. Patient come and then I see, okay, you has been injected into the tear trough. I say, how you say that? We can see. Sometimes we can see also our fault, what we did wrong. So we need to restore this, we need to restore the piriformis, we need to restore the mandible, and only at the end we inject the fat. So these are techniques. You can inject the deep fat compartments directly with the needle, but it's better to inject some areas of the face, like the mandible, with the cannula, because for safety reason, we need to be very careful when we inject the mandible. You see the angle can be injected with the needle, but the mandible must be injected with the cannula. So this is the angle. I want to make an elongation of the angle, and I do suggest to inject right on the bone, because the hyaluronic again demonstrated to act in small quantities also on the bone. So we can really restore bone projection. So these are all the deep bone restoration, piriformis, chin. You see that in older ladies, the chin is coming flat at the projected. So only in over-projected chin, we do not treat the chin. Otherwise, we always treat the chin to restore a good shape of the face. And again, the mandible border with the cannula in the posterior and in anterior layers. You see, it's not painful. She's speaking during my treatment, so it's completely not painful. You can do very quickly. You can do fast reconstruction. So basically, in all my patients, I have like a systematic approach in which we can basically predict the amount of money they will spend for restoration. I'll give you all of that. Why? Because it's important that they come into your clinic and they know that you have a program in your mind. And you're not acting, okay, let's do this today. Oh, maybe tomorrow we do that. without any program. We are doctors, so we make a diagnosis and we make a protocol. And the patient need to think that we are following this protocol. And they have like a paper they bring home in which I sign all the protocol over a 1 year, and they will follow step by step. And then I tell them, okay, you will see a result after 6 months, you will see a result after 1 year. They don't ask me anything in the meantime. You will see a result in 2 years if they are very old. We cannot expect to have impressive result in skin quality after 6 months. We need to restore this production of collagen over time. Sometimes it is important to use at least 1 year. So this is my patient at the before the treatment. This is after. And you see, it's natural looking, not over-injected, and younger. So we can have good results without using any impressive treatments. Of course, I can over-inject the cheeks, I can do whatever you want, but they don't want it. They just want to look less stressed, less tired, happy, because at the beginning they feel they look tired and unhappy, and they want to look natural. So let's move now on the beautification aspect. So now we understood what is the approach for anti-aging that is different from beautification. But beautification is something that is difficult to define. So what is beautiful for me maybe could be not really beautiful for you. What is true anyway is that there are proportions that are considered homogeneous and beautiful almost for everybody. That's why we brought this golden ratio philosophy into fillers, because we thought that somehow, especially when you start, it's not easy for everybody to understand where do I have to inject my patient to let her looking beautiful. Sometimes we inject the mandible and they look worst. So there is a reason for that, because there is a proportion in the face, and of course it's difficult to use the golden ratio for everybody because we have a caliper and we make all the measurements of the faces of our patient. But to make things easier, you can download from the web the mask that Marcard prepared, because he was preparing this mask based on the golden ratio. So you can download this. At the beginning, you can try to overlap the mask to your patient, or you can overlap after the treatment to understand if you did a good work or not. That was I was doing at the beginning to understand why this is beautiful, this is not. Is of course not always like that, but in the main cases it was very useful. There is a lateral view, a mask for men, and it is almost true that what is proportionated following the golden ratio is considered beautiful for almost 95% of the population. And we can say, okay, but this is a kind of ratio that we follow in our times. What we believe now that is beautiful is not considered beautiful maybe in the 30s or in the past. So we see that Marilyn Monroe also fit, and everybody believes Marilyn Monroe is beautiful. But also Nefertiti fit, and also Venus fit during the Greek and ancient times. That means that this proportion are overall considered beautiful for everybody. So if we follow, we can maybe say that it's not perfect, but of course it must be considered beautiful. So that's why we worked a lot about the idea of beautiful proportions, because proportions are okay. But if I see a patient that has a very nice face, but the skin quality and the spots over the skin are so much present, we say, wow, she's nice, but it's a pity for the skin. So that means that we look also at the skin. So we are not just looking about proportion in the first idea. We are not just looking about the face shape. We are looking about many things. That's why we publish it. It's almost ready. You will see in the aesthetic plastic surgery the 5 pillars of beauty. So what we need to change in our patient if we want to look them beautiful. The first thing is the shape of the face. A face that is closer to an oval face is considered more beautiful than a face that is considered long or round. Now we're moving a little bit into oval square, because it's more, beautiful for many people to think that this masculine aspect is more beautiful. But anyway, as a patient or a lady that is more oval is more beautiful than a patient that is square. Shape of the face, proportion that we saw already. Symmetrical face in statically and dynamically proportion. That means that we need to think about our patient also when they speak. If they move too much from one side, anyway, when they speak, we are only concerned about this pathological movement. So we need to consider the correction of this. Skin quality, and very difficult, light and reflection. Because we look at lights on the face, and we know because we make the makeup, we know that with makeup we can simulate a thinner nose or a better forehead. But people, because of Instagram and all these apps, they want to look beautiful even without changing the lights or making makeup. Otherwise, we look fantastic in Instagram, and then when we met, is a disaster because they say, oh, you look better. The good thing if they tell me, oh, you look better in real life than on Instagram, not the contrary, okay? So it's important that we focalize about the lights that we want on our patient. And many times, we never inject patient in some areas of the face, like the forehead. But the forehead is important as other areas of the face. That's why we really need to think about a full facial approach. About the shape and proportion, I want to tell you the story of this patient. She came to my clinic to make a nose surgery. She wanted a nose job. She told me, I want a nose job because I believe I'm ugly. Okay, you believe you're ugly, or you believe you need a nose job? Because this for a surgeon is a different thing. If you believe you're ugly, that means that you are a problematic patient for surgery because you don't really understand what you want. And after the surgery, you may potentially be unhappy. And she said, I believe I'm ugly. You can do on my face whatever you want. Then I understood she was problematic, okay? And then I said, okay, let's go first for injection, but not because I was really thinking, but just because injections leaves you the possibility to check the mentality aspect of your patient, because you are seeing your patient every month, and then you check the response. If after my first injection she is still unhappy and she understood nothing about the injection, it's better to avoid that patient. So we started, and I decided to make her hair this proportion that we saw with the mask. And that was the result. Then the nose looked smaller. So I did no surgery on the nose, but just because I restored the proportion of the face, maybe the screen is just a little bit wider, the face is of course longer. But anyway, because of the proportion, she looks better. And after the injections, she said, I don't want to go through the surgery anymore. I'm happy like that. So proportion are very basical, and we need to understand proportion into the front and into the lateral view, remembering that perfection doesn't mean that we need to be completely symmetrical, but we need to have an asymmetry that is not immediately perceived by the viewer. So if I see the asymmetry immediately when you speak, it's better if I correct. If I need to go deep, finding and searching for asymmetries, these are natural and make us more beautiful. So we need to keep this type of asymmetries. This is another patient. You see, she was very nice. She came to my clinic for a nose filler. But I said, okay, but you're okay, maybe just a little bit of filler can help you, but the skin quality is terrible, and everything is not proportionate. Let's try to work also on skin quality and the other things. So we went through a complete program, and we changed also facial proportion following again the mask. You see, skin quality means a lot to us because just because of the lightening in the skin, she looks younger. So we need to think about skin quality before starting injection. If you do not have lasers, start with peeling. Start with whatever you have at home, retinol, peelings, but start in the same time you start with your injection, because otherwise you will see this and you will be unhappy. Maybe the patient is happy, but we are more critic than the patient many times. You see, the mask fits completely. Lateral, again, she's not bad, of course. But the point is that she can be better with injection. So we can make better proportion for the nose, the chin, and the lips. It's the same for that patient. This is again a story that is interesting because she came to my clinic to inject the upper lip. So, you know, because I will show you in the 3/4 because the upper lip seems to be very smaller compared to the lower, but we don't look at our faces sometimes in the lateral view. We only look in the mirror. So I said, no, okay, we have to inject the lower and the chin to make everything more proportionated. That's what I did. Of course, finally I injected also the upper, otherwise she wasn't very happy. But this was the result after. And you see the lateral. That's why in the frontal and 3/4, she believed that the upper lip was smaller than the lower. And she said, why lower? Then I took the picture and then I showed her lateral view. This is very important. So, first, never put your patient in front of a mirror to check the differences or the things you want to do. Why you don't have to put in front of the mirror? Because we have our image in our brain first, so we will see this and we never see what the surgeon is teaching us. And secondly, because in front of the mirror, patients start making faces. So, you know, if they start doing, no, I don't want you to make this, please, because I want to show you this. Then it becomes a mess. We cannot, you know, show anything. So make pictures and present the picture, even if you have your iPhone. Doesn't matter. But take the picture, frontal, 3/4, and lateral, and discuss with your patient with the picture, because they cannot see otherwise anything. Sometimes just make the picture bigger and show just the detail. Otherwise, again, they will watch, oh, I was terrible in this picture. And they don't see what you want to show them. That was my patient before and after. And then she was so happy that we decided also to undergo to a nose job. So this was the before and this is after. Chin and everything, because I like to play with the faces in general. This is another patient. She looks a little bit fatty. She wanted to be injected into the nose and cheeks. And we decided to make everything more proportionated and also to treat the jawline to have this less represented. So we treated the nose to have the projection into the nose, the lips and the chin. And this is the treatment after. You see, we can really make a difference into the nose surgery, also with fillers. So if you learn how to inject the nose, sometimes the resolution. Look at the mandible. Now we can see the mandible. She is young. So there is no reason why we do not have to see the border. So we need to restore the border. This is another lady, very typical Italian nose. You see, big, not proportionated for the face. So we need to restore everything and make the patient younger. So we need to work on skin quality, proportion, and nose. And we did this without the surgery. You see that filler? Even when we inject the fillers, the nose can look smaller. So we need to know the indication for nose fillers. So which type of patient we can include, which type of patient we have to completely remove from our treatments. And so this is the type of noses. We can treat the saddle nose. We can treat the tip projection problem. So if the tip is less projected, less rotated, we can treat it. Columellar retraction, rim show, dorsal hump, if it's, again, we have some noses that we need to remove from our treatment. Nasal spine retraction, even sometimes after surgery, they remove too much the spine. So immediately the result is very good, but after 10 years, you see that the tip drop. So it's very important to restore the nasal spine. Piriformis, that is not properly the nose, but every patient that have a retraction in the spina nasalis, they have also retraction in the piriformis. So over time, they start having asymmetries into the nasal nostrils. Secondary revision, you will see I do hundreds of secondary revision because I'm a referee doctor for a group of the best surgeon of the nose in Italy. So every time they have problems, they send them to me. Thank to them, giving a lot of problems, of course, because then the patient is not happy and must be happy after my treatment. But anyway, this gives us the possibility to see a lot of different problems with the nose surgery. And this is important, as we saw before, to understand which type of nose is considered for us the best nose. All the speeches are together, so we end quickly. The angle, we need to understand the tip projection that we want in our patient. So what we believe is perfection from publication is a facial angle of 106 degrees. Of course, we do not have to measure, but whenever we see a nose that we consider a beautiful nose, that means that we have 106 degrees. You see that the princess that have 1 and 3 is not as beautiful as the others. So it's very important for us to understand that if we give a little bit of deep projection and rotation to our patient, especially also during the aging process, this makes the noses looking better. So let's see some before and after. You see this patient. We did the chin, deep projection, and lips. So a lot of doctors believe that these are just temporary results. But hundreds of my patients, they never come for the chops. So if we do the injection in the right plane, and we do not over-inject per session, the gel will act as a graft. So we have like a perichondral activity on it, and it will stay there forever. Of course, we need a little bit of touch-ups at the beginning until we reach the result, because for safety purposes, I never do suggest you to inject more than 0.1 per point, maximum 0.2 for some areas. But when we reach the result, after 12 months, we even have a better results because everything is integrated. So multiple patients do not need surgery anymore after. You see, this is a patient again after 2 years, and then after 7 years. She doesn't need the surgery anymore. The gel is there. I never touch it up anymore. And it seems to be, you know, like a surgery. Again, we can really correct everything, but we need to do by sessions. It's very important to understand that if we want to do this in a 1 session, it's impossible. No?
And how many sessions you spend to realize it?
For her, we took 2 years.
2 years.
Yeah.
You need
And
6 sessions.
yeah, at the beginning, we do 1 session every 3 months because we need to allow the gel to fix. Otherwise, if I inject again, I have an immune reaction and they will reabsorb previous and new gel. So at least 3 months in between the session, or 1 every 6. And she was sending me pictures. I have all her pictures in my phone, so whenever you want to see that is true, I'll have my phone here. She was sending me then after the 2 years picture, because I said, okay, just send me the picture, because if you don't need, there is no reason you come every time, every year for checkup. So she was taking pictures and sending me every year. And she said, okay, doctor, I think I don't need to come anymore, because after 5 years, result is good. So we need to have the good patient, of course, younger patient, because otherwise we need to touch up because the nose is aging, and the good indication for this type of treatment. You see, we can completely correct. And sometimes they look also more symmetrical because of the injections. So the plan, how we do the treatment. This is very important to understand that many publications, and I speak about publication because this is what you find all over the web all the time, and it's very important to support our theories with the publication, give you the idea that we can work on the nose in a multi-plane injections. So that means that we can stay over the periosteum and over the perichondrium, we can stay over the muscle, and we can stay under the skin. But the revision protocol that especially Chinese gave us the feedback, because they do a lot, they have a lot of problems. They said, we do not advise to do the multi-layer because this is the only possibility that you have to have necrosis even after treatments in times. The only safe plane is over the bone or over the perichondrium. Okay, so very deep where the vessels are not supposed to be. And to stay in this plane is very difficult because it's very easy for us, especially if the access point is in the middle of the nose where the cartilage is located. You think you are in the right position, or you go through the cartilage and you go into the nose. This is one possibility. Or you are too superficial because it's very difficult to find the right plane. So our access point must be over the bone all the time if we want to treat the tip, and we must stay on the tip if you want to treat the columella and this area over the cartilage. as you see from, again, a publication. So we can inject into the dome area. We can inject at the alar margin to the spine or over the columella to have the different type of correction that we need. Anyway, okay, we assume that we need to stay deep, but we need to stay also central, even for the access point. If my access point is lateral, the chance to go into the dorsal artery or to the lateral artery of the nose is very high. So if I stay central from the access point and then I move lateral, that means I can correct the lateral part of the nose. But I need to stay central. So I come from the center and then I move lateral. Because generally, in the central part of the nose, there is nothing. I say generally because many patients, they have surgeries, and then anatomy could possibly change. So keep an eye. But you inject a little bit of anesthetic. I do suggest to avoid epinephrine. Many doctors, they do epinephrine for shrinking the vessel and reduce the possibility of embolism. But if you use epinephrine, you have two problems. The first, you have whitening. That is the side effect that you have when you inject into a vessel. So I cannot recognize a quick problem that I have. This is my first problem. That's why I don't use epinephrine. Secondly, because of the epinephrine, again, you don't have the bleeding from the needle when you make your puncture before the cannula. So when I do my puncture, I put the needle, and if blood comes out of the needle, that means that I'm in an artery. So, okay, this is not the wrong place to enter, and then I can change. This is also a good point. So you have two measurements of your position. So stay central all the time. Technique, we do this anesthesia in different areas of the nerve supply of the nose, just a little, because we need pain. Pain for us is important, again, because if I have severe pain after I am injecting, again, this could potentially be a sign of embolism, because it's not really painful when you inject. If I inject my lidocaine, then I inject with my cannula, I check all the time. Tell me, please, if you have severe pain, because all the painful things they already had during the needle insertion with the anesthesia. So the feedback is important. Again, we insert our cannula, but we make a retrograde injection to be, again, safer. So you see, from the tip of the nose, we can move all along the dorsal hump, and we can go also through the columella and ala correction. The only thing we cannot do is to treat and overproject the tip from here, otherwise the gel will flew up the insertion point. I see. It's not painful. She's speaking during the treatment. I want them to speak, because then I can understand if I'm having any problems. So we speak like a natural thing. And you see, we can do also this area from here and correct. And this is the patient that you saw before. This is immediate correction. We can treat also very, very saddle nose. Look at this. This is after surgery. They removed, I think, too much. Again, to restore the angle that we saw. So she had a quite good angle, but we can give her a better angle and a better lips. This is the correction, again, of a nose with a big hump. Minimal correction. This is one of the patients after nasal surgery from a surgeon. She said, I'm happy, but the tip is like drooping a little bit, because we have a kind of supratip deformity, just a little, but patient after surgery, they are very sophisticated, they can see everything. So we can correct this with the filler and give, again, long-lasting results. Again, post-surgical nose, and this is after. So we can make the nose anyway better, because we project and we give better angles, also after primary nose. The V deformity after surgery, that we can correct with the filler, and the gel acts like spreader graft into the nose. And what about the male? There are a lot of male patients that wants to be rejuvenated, beautificated, but they do not come absolutely to us, because they say, if I go there, I look like a female after. So I don't want any treatment, because the approach for male is completely different from female, also for the nose. So it's important that when we treat the nose, what we want to restore is 103 degrees maximum in the male. But we can anyway proportionate in male, giving anyway a good male aspect, but again, treating and making good projection also for the chin. Again, little deformity after surgery. This is a guy after 4 surgery. So I did a secondary correction with the filler because she was exhausted about the surgery. She said, I don't want to undergo to any surgery. Look at the tip. This is after the injection, looks better. And they give him like this saddle nose with very projected tip that looked like, like a deformity also of the septum, but it wasn't. It was just the soft tissue. And this looks like more masculine after. So what about the male beauty? The first thing we need to understand about the male beauty is that what we consider beautiful in men is many things, but especially the square face. During the aging process, the man loses the square face and become more feminine. Exactly as we age, because as female, when we age, we become more masculine because we become more square and sagging. So the first thing to consider is the square face. Tom Cruise is a beautiful man, considered beautiful at my time. So maybe you consider beautiful other men, but for me it's still beautiful. Square face, low linear brow. So we need to keep the brow of a man low. I see a lot of doctors that do toxin to men and open the eyes like female. And then when they come to my clinic, I say, oh, wow, you have a really good brow lift. They look terrible. So please, let's keep the brow very low. And sometimes when we want to open the eyes of a man, just inject the eyebrow to give more structure to the bone. Because when the brow is going down, it's because they are losing. As we lose some other areas of the bones, they are losing the bone projection that is generally more protruded in men than in female. I also see female that are injected there and they give the male aspect with the overprojected this and they look like a sausage over the eyebrow. So also this we do not have to do. So low linear brow, flat cheek. We like the apple cheek in female, but men, they have a flat cheek. Please do not inject in that area. Lower lip bigger than upper lip. This is important proportion in men. It's very difficult that men have an upper lip bigger than lower. Maybe they have bigger lips, upper and lower, but never the upper lip bigger than the lower. And so we need to keep this proportion. So let's see the role of a square face in attractiveness in men. So if we really consider this square face nicer, this was Tom Cruise before all his surgeries, when he was younger. He wasn't really attractive. So when I saw this, I said, okay, I changed my mind. He's not really attractive. But then he had, fortunately and luckily, his surgeries, and he became to be square. Then maybe he went to a surgeon during his aging process that didn't have very clear the ideas about the aging process in men. So he did his rejuvenation, and he became like that. So he loses completely his attractiveness because it looks like, round faces that is even ugly in female. So of course we need to restore the fat compartments, but we do not have to overtreat our patient. It's very important to keep natural look and in my position also attractiveness. But what happens if we have a man that has everything, square face, lower brow, flat cheeks, but the lip balance is not respected? He looks like a female. So there are many men that wants to look like that. But let's understand before injection if they want to look like this way or they want to keep their masculine look. So always remember that. So when a man comes to our clinic, we have to take into our mind very clearly about this proportion. So the first thing we think in this man, he's 60, and he said, I want to rejuvenate. So we think maybe that the nasolabial fold are the main concern of this man. But how we can understand? Again, I have in mind that I need to restore the square face. So my injection point will be the mandible anyway. But I asked him a picture when he was 40. And you see, the nasolabial fold were deep anyway at 40. So if I try to restore, I will make only a bumping central face, but nothing rejuvenation. So what we need to do is to work to restore this square face that he was having at 40. And into the lateral view, we need to understand exactly where we need to inject. As you see, I always inject superficial compartments in my technique. That in man is a little bit different, because in men generally we have the masseter that is hyperactive. So this area in which female are very weak, they are quite good. They lose into the two circles, so in the middle. So instead of have our insertion point into the middle of the two circles, we have our insertion point into the area that is over-injected. And we inject and undermine everything, as you already saw that was I did in him. And of course, I need to treat also eyebrow and forehead. So what we have is a natural rejuvenation that looks like a lifting effect, because we rejuvenated in the right area and compartment of the face. But he keeps his nasolabial fold. Again, the eyebrow, you see, we need to restore flat eyebrows in men because they look more masculine. And we need to keep the aspect of a man natural over time. So this is one of my patients in 10 years. So she had treatments over 10 years. And I hope it looks better now at 40s instead at his 30s. This is another man coming again for rejuvenation, especially for scars, because he had scars, you see here and on the neck. But then I decided to make a rejuvenation, complete rejuvenation. And the aspect is anyway natural. You don't see that it was injected, but it's restored, especially in the lower face. So let's go about the side effects, because we need to know that anytime we inject, we follow some rules, but sometimes, anyway, we have problems. So instead of not injecting, it's better knowing how to deal with side effects. So what about the nose? That is, of course, over all the face, but on the nose more than other areas. Common side effects is the pain. So it's okay. Hematoma, edema, asymmetries, hyper or hypocorrection. Less common. If you do not treat in a proper way, you can have granulomas, and they need surgery for remove that granulomas. But what is very impressive for us, and we are really afraid of treating noses, is because of the vascular occlusion, necrosis, and blindness. That means that is actually considered a not resolvable side effects. So if you make a blindness, it is forever. Why we have the blindness? Because the connection between the inner carotid and external carotid is from exactly the nose area, as you see there. So from the dorsal artery that goes into the orbit through the supraorbital and supratrochlear arteries. So it could be that they have a connection, it could be they do not have them, but we don't want to discover if they have or not connection. We want to stay safe. Very often we have side effects that are very little. We don't even consider them like a side effect. This is a picture from one of the doctor. He sent me this picture. She's red after 3 days of my injection. Very little amount. I did 0.0 something for a nose tip correction. I think it's just an hematoma, right? And I said, no, it's an embolus. So you need to inject with hyaluronidase. Because if it's an hematoma, it will stay there, and after injection, maybe it would be worse. But if it's an embolus, after injection of hyaluronidase, it will improve. So there is no reason why not to do the hyaluronidase. And you see, this is a very terminal anastomotic area. So if you make a necrosis over the tip will be completely dark over at least 7 days. So if followed my advertise instead of not following, because if you are not following, then you have necrosis. So you see, after 12 hours, the nose was better. But for me, it's very important to let you understand that better doesn't mean resolved. This is considered, for me, livedo reticularis. That means that you need to inject again. So when you see that, you need to inject until you do not have a quite good resolution, and the skin appearance of the nose is quite good. Otherwise, this means that you split the hyaluronic into smaller particles that move into smaller vessels and gives you only few areas of necrosis. So better to do hyaluronidase. There are no side effects about hyaluronidase. I had a colleague, because I treat mainly side effects now in my life. So one doctor, she did on herself injection into the temporal zone. And after 1 day, she was like that, completely insensitive, and the necrosis was starting in the back of the head. So she came to my clinic, and that means in this case that she took the temporal artery at the bifurcation, also for the deep artery, because otherwise you do not have pain in your back of the head. So it was a very big embolism. So I decided to inject hyaluronidase, and then I did almost 600 units in one session, and 600 units the second day, and 600 units the third day. So a huge amount, because the hyaluronic was completely blocking the artery at the Doppler, so all the gel was into the artery. And after it goes into the artery, it mixes with blood. So then smaller particles runs everywhere. So I injected all the temporal and hemifrontal area where I thought that maybe the gel could possibly migrate. After 3 days, she seemed to be okay. The 4th day, she started having livedo on the contralateral zone. Anytime I see that, I don't think it's just nothing. I think, okay, gel moved because of the connection from the head on the contralateral area. Then I started 300 units also on the other side, but just for caution, I did both sides, and then I still kept injecting also this side. So we did in 1 week, every day, 300 to 600. She had no side effects, but she ended up with a small necrosis just in the middle of the nose after 2 months. So you can imagine the circle is very deeply integrated, so it's better to keep watching your patient day by day. But even though I did such an amount of hyaluronidase, she was perfect. No dissolution of her hyaluronic, because they try to frighten you. Don't do hyaluronidase because it's allergic. It gives you the destruction of your hyaluronic, your own hyaluronic. It's not true. You can do it, and especially when you have any small suspect, it's better to inject hyaluronidase instead of waiting. More you wait, more the diffusion will be. So even when you inject, anytime I inject, because I had 4 occlusion in my life, that is, it seems to be not a lot, but it's a lot, because when you see the whitening over the head, and you say, okay, the disaster is coming, I started injecting hyaluronidase immediately. But even if I do the lips and then I see a little whitening where I suppose the artery is, I start injecting hyaluronidase, because it's better to pre-treat immediately instead of not treating. Every time I see the occlusion, I never had necrosis, because I always injected immediately hyaluronidase. So 12 hours later is okay. So this is the circle. You can have blindness. How you can have blindness? There is no clear reason for that, but for sure, if you inject a huge amount of product, is a risk factor. If you inject nose, temporal zone, and tear trough, you have a higher risk than in all the other areas of the face. And of course, if you do not know the anatomy. So the first thing is that anatomy of fillers is different from anatomy from surgery. So do your course about the anatomy, fillers in anatomy, because otherwise you never understand completely. That's why we do a lot of courses also in Italy. I run courses on anatomy for this reason, because many times you believe you are in the right plane, but you are not with the cannula. And you see, I see a lot of patients also after problems, because they are sending me patients, they believe they can solve them, my colleagues, but then sometimes it's too late. So my colleagues did hyaluronidase in this patient, but you understand that if you don't know how to do hyaluronidase, it's not effective. So it's very important that you understand how to do hyaluronidase, because if you are in mind, then you can deal with complication. So he injected after secondary rhinoplasty, and this was after 2 days only. So it really took the artery. We had the blistering, we have the bulla, we have everything, because possibly he injected on the alar exactly there, where the lateral nasal artery crosses with the dorsal. And what was worst is that after 3 days, the patient told me, I thought that something is going wrong on my nose, but the problem is that I called the doctor, that's why he sent me the patient, because he knew that I felt heaviness in the upper lid. Heaviness in the upper lid is the first sign that the gel is going back into the orbit. Because we had a case in which the surgeon do not took into any account the symptoms, and 3 days after, the lady was blind. So think always that this is a sign that you need to consider in your side effects point, especially when you inject the nose. So that's why I decided to inject it. Of course, I injected also in the supratrochlear and supraorbital area. Your treatment protocol. You need to use hyaluronidase. So minimal doses, 200 to 300. Okay, so if you inject 10 units, means nothing. You need to inject 200 to 300 units, and you need to re-inject every 4, 6, 12, or 24 hours. How do I decide when to re-inject? First, very often you have edema. If you have a big edema, there is no reason to inject again. Otherwise, you inject and you make more inflammation, more suffering. So wait until the edema is gone and you re-inject. Or if you are in a very dangerous area like orbit and you have the first signs of blindness, you can inject every 4 hours. So I was invited in a anatomy course in Bangkok. And we were doing this anatomy course, and I was with Ho Chi Minh, that was the first anatomist in the world. While we were doing the course, one of the doctors into the class was called by a patient that she has been injected 2 days before, and she was blind. So luckily, in Bangkok, the cosmetic is done in 2 hospitals. So the chief of the clinic there, the hospital, said to the doctor, okay, tell the patient to come into the clinic and run here as soon as she can. So she came into the hospital, she was recovered, and the point was that instead of doing what generally we do for blindness, that is high bolus of hyaluronidase retrobulbar, we decided to treat that patient with smaller dosage every 4 hours. Not only into the orbit, but over all the area surrounding with the vessels that are, again, because this is what we do. Generally, when we have necrosis here, we treat all the area. But for the blindness, till now, we only injected retrobulbarly. That, I think, was wrong. So all the colleagues agreed about that. So we started injected every 4 to 6, depending, of course, because during the night we do not inject it. The course was 1 week, and after 1 week, the patient recovered the visus. So it's important to say that till now, maybe we were only lucky. It could be. But actually, there is no case reported, so possibly you will find this paper published into journals very soon, because they're taking all the details, also the tomography. But till now, we didn't thought that we could recover from blindness. This is the first case. And I'm telling you, as a first thing, because, you know, no one of the ophthalmologists know how to deal with the patient. If they have blindness, they go to the hospital, they will be recovered by an ophthalmologist, so they will become blind for sure. So it's very important that you follow your patient and you tell the doctor, the ophthalmologist, what to do over the recovery time if it happens, or if it happens to a colleague and you want to help. So in this way, if we do not have side effects, it's good for all of us. So I always give antibiotics as a protection and aspirin. That is very important because for the coagulation of vessels, aspirin is very protective. Nitroglycerin paste, because, and this is good only if you have artery occlusion, not vein occlusion, otherwise it gets worse. Heparin, if you think that is good, but aspirin is enough generally. think about steroids and all the other things, but these are only secondary. The first thing to do, a patient comes to your clinic with a suspect of necrosis. You start injecting of hyaluronidase. You give them aspirin, antibiotics for skin protection, and steroids or anti-inflammatory agents, even better, because we want to reduce inflammation and let the hyaluronidase act. And you follow, this is your filler crash kit. Please take a pictures, save it, and remember to have all this in your clinic. So if we want to inject and apply nitroglycerin paste, and we do not have nitroglycerin paste in our state, like in, I don't know if in Bucharest or in Cluj you have this nitroglycerin paste, because in many countries not allowed. What you can do, that's what I do in Italy because it's the same, I use the one that is used for patients that have breast illness. They have like stitches that they put on the body with nitroglycerin 1% or 2%. So you take the stitch, you cut in 4, and you put in all the blood supplies that you want to enhance. But remember, the nitroglycerin reduces the blood flow, so they can, loses their consciousness. So better if you apply these stickers when they lie down. And then after half an hour, they can come out of your clinic. So this is my patient. It's not mine, it's my doctor friend patient. But anyway, he came, I injected every, day. This is after 3 days. And this was after 5 days. So even if we thought that we already had necrosis, so many other doctors tell you, it's too late. I'll tell you, it's never too late. So start injecting. Because anyway, maybe you don't save everything, but you save more than a half. Because when the necrosis is in this area, we know from surgery, necrosis will spread all over. So maybe we made a very small occlusion, but the necrosis will involve a very big area. So maybe it's too late for that small area, but not for all the surrounding. So, of course, if everything is black, you can start injecting all around. But anyway, you will save the skin all around the necrotic area. So this is a clinical case. Number 3, again, another surgeon, just edema. But very long-lasting edema is, again, a sign of embolism. So I did hyaluronidase, 2 days after second session, 2 weeks after the embolism, totally recovered. So sometimes we need to guess if it's or not a side effect, and it's better, again, to inject instead of not injecting. Because if it was just edema from the hyaluronic acid, it would increase after hyaluronidase, because we know that during the dissolvation of hyaluronic, we have edema. Okay. So recommendation, first of all, know the anatomy. But sometimes we know the anatomy very well, and things happen anyway. So soft injection force. Anytime you force, you are in danger for 2 main reasons. First, if you need to press too much, you are changing the position of the needle. So maybe you did a test in that point, but because you're pressing, the needle moved, and then you're injecting into a vessel. Second point, high injection force means that you can win the force of the blood that is coming in this direction, and you're pushing the gel inside the artery because the force is stronger than the strength of the blood flow. So anytime you have any type of impediment in your injection, don't do it. Change position, make your test, and then inject. Or if you want to inject very strong gel, change the size of the needle, because in this way, you are very soft in injection, and then if you see something around like whitening, you know that you need to act because you are in a vessel. Slow injection, same point. Slow injection leave you the time to understand if something is becoming white or not. So it's very important to follow. Never be in a hurry, especially when you're injecting very difficult areas like noses. Sometimes I have patient every 15 minutes. I'm a very fast injector. But if they need to do the nose and they come, okay, can I do this today? I say, no, sorry. For the nose, I need at least half an hour. I inject a little, then I watch, and the patient need to stay in my clinic for 2 hours after to be sure that nothing's coming after, because maybe I injected a vein, because the reaction will be late onset in veins. small amount, and first of all, know how to deal with complication, because more you do, more possibility you have to have at least one side effects in your life. So if you know how to deal with them, you can for sure have no problems. I had 4 embolisms, but no 1 necrosis in my life. So it happens also if you are very well experienced. And if we say, as experienced doctor, I never had a case in my life, would you believe when it happens to you, oh, I'm stupid, or what I did, this is not true. Anytime you have a surgeon in front of you, older, 1 year older than you, he had at least 1 complication more than you, at least. Sometimes hundreds of complications. So it's better to know how to deal with complication instead of saying, I'm not having complication in life. Okay, thank you so much. Questions?
How much you inject for nose?
Okay, I inject generally 0.1 per point. Only in the spine, that is a safer area. So if you are right over the bone, there are mainly nothing there. I can inject 0.2. But on the dorsal area, on the tip of the nose, especially if I need to correct the deviation, so one side, never more than 0.1. And cannulas must be at least 22, because smaller cannula can go into vessels on the nose. So never use 25. Better to use 22. And sometimes you can have problems in moving because they are longer cannula. When they are 22, they are longer. So you start here and then say, okay, now I can't go there, so I cannot do this. So you just bend the cannula with the cap, not with the hands, otherwise you have contamination. So you put the cap and you bend exactly in the point where you want the angle, and then you go easily, and it will follow exactly the nose. It doesn't break. Okay? Other questions? All clear? Tired? Really tired, okay. So thank you so much. Don't forget to follow.